I have been reading the Sensible Medicine Substack for quite some time, and I joined and became a founding member. It's a fantastic Substack. I encourage everyone to subscribe, to join, to support it. One of its members or its founders, or writers, Dr. Adam Cifu out of the University of Chicago. Since he's local, I actually reached out to him, and I was super excited that he even agreed to talk to me on the Substack app, and we've been communicating by email, and he agreed to come on Healthcare Musings, and I'm super excited. And we had a wonderful. He's a distinguished professor at the University of Chicago, a distinguished and award-winning medical educator, author, hundreds of peer-reviewed published articles, and so I really wanted to get him on the show to talk about medical education, how it's changed, my exasperation sometimes about the training, and how I feel it's gone awry and off track. And his wisdom and his insight was absolutely fantastic, and it was a great episode, and it even inspired a guest post that I'm going to submit to the Sensible Medicine Substack that I pray that they accept. And so just wanted to kind of preface that and give you kind of an insight into such a fantastic conversation. He's a super sweet guy and a great leader and mentor, and I learned a lot from this conversation. So enjoy. From Faith Forward Media, this is Healthcare Musings. I'm Dr. Hashem Hasabala. Welcome, everybody, to Healthcare Musings. Hashem Hasabala here. I am giddy with excitement to have Dr. Adam Cifu. He is professor of medicine and general internist at the University of Chicago, right in my backyard. He received his MD degree from Cornell University Medical College in 1993 and completed his residency training at Beth Israel Hospital in Boston. Before joining the University of Chicago faculty in 1997, Dr. Cifu is a general internist, practicing both in the inpatient and outpatient settings, and medical educator and researcher, which is why I wanted him on the show. He's author of over 140 peer-reviewed publications, co-author of the textbook Symptom to Diagnosis: An Evidence-Based Guide, and for the general lay public, he also published the book Ending Medical Reversal. And I'll put links to those books in the show notes. And since 2022, he's been writing for Sensible Medicine, a Substack that I'm a founding member of. Fantastic. I think everyone should subscribe and support their amazing piece. Hopefully one day I can get a guest post
We're
on
waiting for
Sensible
you.
Medicine. This is the main thrust why I wanted him on the show. He's had the Department of Medicine Award for clinical teaching at the University of Chicago. He also has the Department of Medicine Award for preclinical teaching. He's a distinguished educator and mentor from the Biological Sciences Division and the University Academic Communicators Network Excellence Award. He is a master in the Academy of Distinguished Medical Educators at the University of Chicago. And Dr. Cifu was selected as a favorite faculty member by the graduating class of the Pritzker School of Medicine at the U of C 17 times, which is exactly why I wanted him here, because they don't make them like they used to. And I wanted to get his thoughts about that. Like, it's just, I trained at Rush University Medical Center here in Chicago. I was born there. I did all my training there. It was a different world. We didn't have work hour restrictions. We just, I remember being post call in the unit. It's 1:00. I have a ton of work. And my senior's like, I want to go home. I'll see you later. And just left, right? And what am I supposed to do? And I just did it. I mean, you just got the work done. It's a completely different world now. And I just wanted to begin our conversation, kind of get your thoughts about how it's evolved.
Yeah, medical education definitely has evolved a ton. I think that's true for both, undergraduate medical education, right? Medical school education and graduate medical education, residency. And that's probably due to a whole bunch of forces. And, in some ways, I think we have to admit it's evolved for the better, right? What you and I went through was not great, right? It certainly wasn't great for wellness. It asked too much of us. um, put us in situations which probably put patients at risk. The sort of story that you just told, I think where I faced that most was in the emergency room as a resident. Um, where this was kind of before emergency medicine was really a field, and I loved working in the emergency room. But we had an internist of some sort who would work the night shift with us, sort of 8 to 8, and usually at midnight that person would go to sleep, and it was like, see ya. Um,
Yep.
and I mean, that was absurd, right? We had a second year resident and a senior resident who was just taking care of everybody who came into the emergency room all night. Like if I went to the emergency room with a problem, that's not who I would want to be seeing. Um, and so we have to admit, like, there were reasons to make these changes. But I do agree with you, something's been lost, right? It is harder to learn the medicine that I think people know in the current situation. There's more stuff competing for curriculum time in medical school. And then in residency, for a resident to really sort of master the information they need to master, it takes deliberate practice. For you and I couldn't get away from learning chest pain, right? Because I was
Mhm.
admitting, 30 patients in a year with chest pain. Even if I tried to not learn it, I would learn it. Now, we really ask the residents to sort of make the most of every case, get the most out of it. And for the kind of committed, driven residents, that happens. For either the less committed or the people with more going on in their lives at the time, maybe they fall a little bit short.
Yeah. The problem I have is that the work hasn't changed. Like critically ill patients back then are just as critically ill now, right? The work, like patients don't go home at 5 o'clock. They don't say, "Oh, great job, guys. We'll see you tomorrow morning at 7." That doesn't work. People come in that night, and I have to recruit new trainees in critical care, right, which is where I am, and it's just a whole different ball game. And I feel like they're being, and I want to get your thoughts. I feel like they're being set up for failure. Do you think that?
Yeah, it's interesting. I mean, when you say set up for failure, right? I think there's so much in that, right?
Hmm.
I still think that we do a good job of training the people to do the job when they're here doing the job. I think maybe where we're setting up people for failure is that the field that they're entering in, they're a little bit less prepared for what it demands of them. And so we may be setting them up for a career that they're sort of less happy with, less satisfied with.
Hmm.
And that's sort of where the failure is. Um, I see it, and a lot of these things are subtle, a lot of these things are hard to measure. Boy, you have trouble recruiting intensivists. We have an impossible time at recruiting generalists.
Yeah,
There are days that I feel like my field is just dying. And
yeah.
I think to some extent it's that when people come out of residency, they don't feel as prepared for, going into practice as a general internist. Um, and because they haven't been faced sort of independently with lots of things, they feel like I need more training. I need more training in a field that is going to, that's more masterable, right?
Mhm.
Because with more time and a smaller list of problems that I have to deal with, maybe I feel more comfortable with that. I actually think it's just delaying the inevitable of being overwhelmed with what you face, right?
Right, right.
With all of us, that first year out of practice when we're on our own, no matter what we're doing, we're like, oh my God, I don't know enough. And do I have the right people to ask? That's part of it. Um, but I think you're right. Our job is not only to teach people, how to manipulate a vent, right? But
Hmm.
it's to sort of get through their career in a way that's going to keep them well and keep them working and keep them happy, because we're training people to work for 30 years or else we're kind of wasting our money on these people who are training.
Oh, absolutely. Do you think I think burnout part of it is that there's a mismatch in expectations. Is that training is like I remember again, I was an intern. It was overwhelming. I was in the CCU. They didn't know where to put me. And they said, "Oh, we need an intern in the CCU. Go." And I
Right.
was on call. First day, right? I didn't sleep. We had so many admissions with MIs. I forgot to order heparin. I forgot to order EKGs. This was all before EMRs. It was all written. And then later on in the month, I brought a patient, attending cardiologist brought a patient down to the CCU for diuresis. I completely forgot to order the Lasix. And he
Yeah.
came and he gave me a hard time about it. He
Yeah.
wasn't screaming,
Yeah.
but it was a very uncomfortable situation, right?
Yeah.
And I realized I didn't go home and take a mental health day. I realized that my system is not working and I have to
Right.
figure out the system that is going to work because clearly I forgot a critical thing that that patient needed. And he told me I could have kept the patient on the floor and he shooed me away, right?
Yeah. Yeah.
But rather than take a mental health day, which is now I see residents, if an ICU nurse yells at them in a very tense situation, this resident goes home and then doesn't come back the next day.
Right.
You figure out the way to get around that so it
Yeah.
doesn't happen again because clearly what I'm doing is not working. And I just that kind of resilience, and we saw it in the pandemic, right? The old farts like me, we survived relatively intact, but our younger colleagues did not. That onslaught came, and a lot of them were not in a good shape, right? And
Right.
like, what do you think about like, what are your thoughts about that?
I lo I love the quote that you know you're old when instead of complaining about the people who are older than you start complaining about the people who are younger than you, right?
Absolutely.
So I think I would say I agree with you, but let me add a little bit of nuance. You know,
Please.
what we went through was awful. I'm not a crier, you know. I cried a few times during internship with people berating me for stupid things that I knew at the time, you know, were stupid. Um, and that was a bad atmosphere. And we managed to burn out some people, you know, much younger at that time, right? Um, I can still name, you know, a handful of fellow medical students, a handful of fellow residents, you know, who didn't end up in a career in clinical medicine, you know, probably because of how toxic and obnoxious and nasty the training was, right?
Yeah,
Like we had to get better with that. On the other hand, you know, the field is hard, right?
it is.
There's a lot, there's not only a lot of stress in the field, but there's a lot of drudgery in the field as well.
Mhm.
And I do think we don't really do a good enough job of being honest with that, of letting people know what that's like, of maybe giving people the appropriate off ramps to say, like, listen, you know, this is what the field is actually going to be. You know, maybe after the first 2 years of medical school, you know, if this doesn't seem right for you, let's help you find something else. So we end up with a better match between the people who, you know, really can do and love and thrive in the field we have, you know, rather than end up being a field where it's, you know, it's not going to help anybody, right? They're going to be unhappy. Their patients are going to be unhappy. Um, I am I'm careful about COVID because, and I think we, you know, we all had such sort of unique situations during that, right?
Yeah,
Um,
yeah,
I personally think, you know, we probably, I don't think there was an alternative, but we asked too much of our medicine residents during that time. It was kind of like, you know, I won't curse, but you know, the excrement flowed down and they were the one who sort of had to take care of it.
right.
And I don't know what else we could have done. You know, it was a miserable time.
Mhm.
And I, you know, had it pretty good. Sure, I did extra clinical time and blah, 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 blah. And I was probably more nervous because I was old enough that if I got sick, I actually was actually at risk, you know, rather than
Really?
20
Wow.
something. But um, you know, I am still, somewhat scarred by it, right? I see people wearing masks and I'm like, oh God, still, it brings it all back to me.
Right.
Um, and so I go a little bit easy on that generation that I think we're just dealt a miserable hand. And it's not just the doctors, right? I mean, it's the poor people who are in high school and beginning college and whatever,
Yeah.
who had to deal with a completely different, I don't know, environment.
No, absolutely. And what I when I'm reading in your readings, reading your writing, I love the fact that the learning is in the work. And when I talk to medical students that are graduating now, and everybody that I have who rotate with me, I tell them at the end, do not get sucked into the culture of entitlement
Mm,
because I'm not waiting for you to graduate training for you to come and join me. Right? We're
yeah,
not. The world is not waiting for you to come,
yeah, yeah,
but they come out saying their attitude is, well, why should I do that, or why
yeah,
should I do like that like it's like because you had it hard. Now my daughter, my eldest, is now a first year med student, so like but the work is not, the work is hard, like you said. And what I like is the learning is in the work. The patients that you're seeing, every single one teaching you how to be a doctor, and that's where it is. And I just sense that there's, well, whatever, it's not my job, not my problem.
yeah,
Shifts over, okay, done, and move
yeah,
on. That kind of an attitude, I think it's really detrimental.
yeah,
And then another, like, so kind of, well, there's so many things I wanted to ask you, but like that, I love when you say that the learning is in it. It's still a guild. Do you think our field? I think it's still a guild,
yeah,
like a like a mason. I hate to use that word. That's loaded, but like a blacksmith or it's still a
yeah,
guild, and
yeah,
there it's residency is more than just it's an apprenticeship, right? And the
yeah,
more you do, the better you will be.
yeah. You're clearly a better parent than me. Neither of my kids are going into medicine, so um, you, you were a better role model. Um, so it's funny. I think back to what my third year clerkship was, and that sort of began with, here's your pager, here's your team. This is when the final exam is, good luck, kind of thing.
Yeah,
And I spent 20 years, as the internal medicine clerkship director here. And if I pitched a clerkship like that, right, I would have been fired. It was like, what the hell? You're supposed to be teaching, you're supposed to be doing a job. And and I think that comes a little bit from the student expectations, right? That people come in, I'm paying a fortune for this education. I'm used to people teaching me, that should continue. Um, where in the past it was okay, you've made the transition where it is going to be learning on the job, right? It's going to be um, sort of mentored practice, and this is how you're going to learn, very much the way the guilds have worked since whatever, the 15th century, right?
yeah,
Um, why did that change happen? I think it's a little bit expectation. I think it's a little bit us, right? We have all these people who are making their lives as clinician educators, right? And they sort of need to accomplish something. They need to create curriculum. They need to do something for students. Um, but we always do lip service to, oh, this is you have to be ready for lifelong learning, right? Because you're going to leave medical school and you're certainly going to not have enough knowledge to last you your career. In order to keep up, in order to become an expert, you have to continue with deliberative practice. You have to continue learning. And although we say that, and it's what we even evaluate our medical students on, right? Is this person good at problem based learning? Um, I don't think we set up the curriculum well enough to actually inspire that. Um,
mhm,
and I've certainly had a lot of people. express disappointment in their clinical years because, nobody paid attention to me. I just feel like a cog in the machine. I'm being ignored. Um, and I think both how we've prepared students for medical school, how we treat students in medical school doesn't reflect that, like, the most important the most important person here is the patient.
Right.
You have to help us take care of them. That's an unbelievable privilege to be able to do that. And if you do that well, you're going to learn a whole hell of a lot with that.
Yeah.
Um, but that means being there a lot, and that probably means fewer lectures, fewer preceptor groups, more call, less of a didactic curriculum. Um, and that feels maybe like we're giving less value, but I don't think that's true. Mm,
I completely agree. Like the the patients don't always read the book, right?
yeah,
The only way you get that nuance is to see
right,
more patients, right? I mean,
right,
I know a lady came in, she had pneumonia, and this was after I finished training, and the primary asked me to come see her, and I came in at night and I saw her, and her X-ray was weird, and she was breathing funny, and I thought she had a pulmonary embolism. She didn't, and I just said, I'm passing to the primary, just check a troponin.
yeah,
Next call I got was from the cardiologist. She had wide open MR. She was in the cath lab, got a
yeah,
balloon pump. She was having an MI,
yeah,
and everyone said she had pneumonia, and she had no
yeah,
chest pain.
yeah, yeah,
So that like it's like when I was reading those articles about nuclear medicine, nuclear submarine training, and I talked to a military doctor about this. The nuclear submarine is not any different. Yeah, like,
right,
it's just as hard, and I can't dumb down the training because you're in a nuclear submarine, and if you
right,
don't do it right, we have nuclear catastrophe.
right,
It's not like that on that scale, and at the same time, this is life and death. I tell students now, know the physiology you're understanding now because it's life and death. If you don't
right,
know what you're doing, this is no joke. You can harm patients if you give diuretic to a patient with DKA, which I saw an attending do because the
right,
potassium is high. What are you doing? You're
right,
harming people, right? You gotta, it's there has to, we have to match
right.
the work to the training to the work.
Right. And I'll maybe use your nuclear submarine comparison in a somewhat different way, right? I think all doctors tend to get their hackles up when the medical error crowd talks about, how few mistakes there are um, in air travel
Right.
versus, what happens in the hospital. Um, and I heard someone once who kind of tried to break down the metaphor by saying, you're flying the same plane to the same airport, and conditions change a little bit, but that's about it. Um, to compare that to medicine, it's basically like we randomly change the plane every time. We move around the airport constantly. We also change the conditions. Um, and so, why medical training needs to be so experiential, right? Is because there's so many uncertainties, right? There's so much complexity, and you can never learn it all. The only thing
Yeah.
you can learn is that there's a lot of unpredictable things which you have to be prepared for. And like you talked about with your patient, a little bit of that ends up being the gut. It's like, there's something wrong here. I don't know what it is. All I know is that I'm uncomfortable with it, and, we need to do more. And I actually think, when students do a good job, I remember a student, it was funny, it was the same thing. It was a pneumonia
Mhm.
case, um, presented by the students as a pneumonia case because that's how the person was admitted. She finished her presentation and said, but there are some things about this that I don't understand. And said, the exam is non-focal. The person had a low-grade fever in the emergency room, but nothing since. There's no white count. Um, uh, and said, I think we should consider the diagnosis of heart failure. When I went to see that patient, lo and behold, that person did have heart failure, no question about it. And it was incredible because it taught that student so much about sticking to their guns about a diagnosis, presenting the case how the resident said to present it because they had to think about their grade. But then also that nobody's ever sure about anything. And sometimes it's the most junior person on the field in the field who will notice something because they have less kind of anchoring bias.
Right.
Sometimes it's the person who's, maybe the most seasoned, though doesn't know the intricacies of the newest tests just because of what they've seen in the past. And that's why I think you need to work through this and you learn through deliberate practice so you see what sort of everybody can offer.
Yeah, no, absolutely. And I love the fact you're reminding me when things deviate from the expected in the airline industry, they just cancel the flight.
Right.
Right? That happened to us in our last vacation. It was bad weather, and they just
Yeah.
canceled the flight.
Yeah.
I'm on my way to the airport, right, with my
Right.
whole
Right.
family,
Right.
and now they're like, well,
Yeah.
sorry, right? But I can't send the patient home.
Right.
Where when they present
Right.
when they present with chest pain
Right.
or
Right.
pneumonia and it's something different, I can't just cancel the flight, right? Because it's different. So I love that. I love that. It's not a fair analogy
Yeah.
because when anything just changes a little bit, then they just say, well, we're not going to fly today.
All right.
That doesn't happen in clinical practice and with real human beings.
I think that's your sensible medicine article. I love that. I love that extension of the metaphor.
Oh,
Um,
perfect. Okay.
it
I'm
would
gonna I'm gonna start working on it.
it would be
Absolutely.
funny. The person who comes into the emergency room, you spend an hour with them. You're like, I don't understand this. Could you go home and come back tomorrow? And
Exactly. When you start having chest pain that radiates down your left arm, give me a call. Yeah, I love it. Perfect. I love it. I'm gonna write it and send it. Um, so I love your insight. It does because I get very frustrated about that. And the other thing that I see trainees struggle with is documentation. Like I'll be waiting for notes to be written all day. And or because I do telemedicine shifts at nights also, and I'm with trainees, and I'm like, what is taking so long to
Right.
write the note? And I tell them almost that you can count on maybe one hand how many times I've stayed after my shift to document because there's a way to do it without cutting corners. But there's the EMRs and how like it seems like they have to have everything encapsulated in the note that happened. And I said, but back in the day when before we would write our H&P, and if something changed, I just go to an open sheet and write, since I last saw the patient, blah 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 happened. And it's like they have to have everything in the note, and so the note comes out at 4 p.m., 5 p.m., and now they're struggling to write 10 notes and they get burned out. What are your
So
thoughts about that?
yeah, so this is really interesting to me, and I'm actually working on a piece right now about where I think the unappreciated harm of um, patient doctor electronic communication, um, the sort of my chart access that patients have to doctors, which I think has come into medicine, through the rest of the world, right, where we all communicate electronically. Um, but I think it tempts both doctors and patients away from actual, like, real human communication, which is critical to healthcare. Um,
Yeah,
and I'll obviously go more into it in writing, but it tempts patients who want to just sort of blow off something to say, well, I'm just going to send a my chart note about this. It often makes doctors avoid conversations by carrying on electronic communications for too long.
yeah,
But to go back to your thing, I mean, I'm really puzzled by what's happened to our documentation. And I feel like it's a little bit of a cop out on our side to blame it on the electronic medical record. There are problems with the EMR, and, a big part is that it's designed so much for billing and not for medical care. And like, I get all that.
right, right.
But, um, you know, nobody has really told us that we have to write the absolutely absurd notes that, like, my finger gets tired scrolling through, all the copied forward and copied echo reports and CT reports and all that stuff, which is somewhere else, really easy to access in the medical record that doesn't need to be there.
Yep.
Um, and why is it that we don't instruct people, listen, you're the physician. What you're here for is for the assessment and plan. That is all I care about. Okay. And
Yeah.
there may be a part of the note that's important for the billing. A lot of that's actually disappeared, but yeah, maybe you got to put some stuff in there and whatever. Most of these things can be designed so that automatically gets pulled. Um, I can't really figure out why we've failed ourselves and have sort of made our jobs harder with all of the sort of crap documentation that now we all do and rely on. Like,
Yeah.
what happened?
It's billing.
Yeah,
It's billing. It's SEP1 bundles. It's
yeah,
reporting.
yeah,
It's all that stuff. Since one of my attendings who now is still in the area, I saw his back in the written days, his consult, they'd be like triplicate forms. Remember those?
yeah,
And he would put his assessment and plan at the very top,
yeah,
first page.
yeah,
Then he'd write the rest of the consult
yeah,
because that's for billing.
yeah,
When I saw that, I'm like, I love that. And
yeah,
when I became a specialist, that's what I do.
yeah,
My notes, the top thing, I spare my colleagues the pain and suffering of going all the way down to the bottom
yeah,
and going through all that stuff. And I put my assessment at the top and my plan, and then the rest of the billing gobbledygook is there. The new documentation rules, like you're saying, don't count that you dump all of the results into your notes. So I've stopped doing that. My note is
right,
much shorter. And
right,
I just put my assessment. This is what I think is going on with the patient and why, and my plan, what I'm going to do about it. And then whatever billing rules I have to do is after that.
yeah.
And I put it at the top for the courtesy of my colleagues.
Yeah. It would be interesting because a lot of the documentation rules have changed for someone to sort of pitch it's time for an EHR documentation renaissance kind of thing, right?
Yeah.
Where we're like, listen, um, this is what's critical to healthcare. And we have gone through 10, 15 years where the outside world was, really kind of screwing us. As that's improved, let's get back to documentation, for healthcare. And how can we do that? And it would be sort of an interesting talk, meeting, whatever, by someone who really knows the billing side of it to say, this is all you need now.
Yeah, I would love to do that actually.
Yeah,
Because I've all over the billing rules
yeah.
and our group, we're a private group and it's very important to us.
Right,
And
right, right,
it's a few things, it's much better,
right,
much better. I'm so happy.
right.
And now it really wants to get you back to medical decision making. But even
Yeah,
then, like I talked to our heart failure coordinator in our hospital, and she's exasperated because we're not using the problem list.
right.
And I showed her, well, this is why we're not using the problem list. It's
Right.
so cumbersome
Yeah,
to use.
yeah,
And if it takes me 10 minutes and I have 30 patients to see, that's 5 hours
yeah,
I'm going to waste.
yeah,
And I'm getting all this pressure to discharge people by 11 o'clock. And I'm in the unit. I don't have any of those pressures. I can't even imagine what you
yeah,
colleagues like you are going through, all those pressures to get people out. And I understand why.
right.
But I told her it's impossible to make, it's not easy to use, and so that's why we're not using it,
Yeah,
right? But then she can't find all the heart failure patients, and then if it's miscoded, then you get a readmission penalty, and oh my god, it's like it's it's again, this is what the EMR has become. It's all regulatory, and it's not just writing what I think is going on and what I'm going to do
yeah,
about it. And the other
yeah,
thing is, I think we did it to ourselves. I remember the days where the unit secretary would be like, is this Pepsid or is this
yeah,
Protonics or
yeah,
are they ordering something else? Dr. Hasabala, can you read this? And go, oh yeah, that's my partner. Oh
yeah,
no, 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 that I know his cat
yeah,
scratch. That's
yeah,
that's Pepsid.
yeah,
That's so dangerous, don't you
yeah,
think?
right, right.
Like
Absolutely,
it
absolutely.
was not a good thing
Yeah,
when we couldn't when I didn't even give the courtesy of my colleague to write legibly so they can even read what I'm writing. They
right,
just come and write this cat scratch. There was a hilarious Dr. Glaucomenflecken
Yeah,
thing about when the EMR went down, and then the 50-year-old Dr. Me
I can
comes
do
in
this.
and writes, and the clipboard was that it was like
the, the clipboard superpower.
absolutely, and it was illegible.
Yeah,
So did we do that to ourselves, or
yeah.
do you think that was inevitable?
No, I mean, listen, you think about what the EMR has brought us, and it's amazing, right? When I see a
True.
patient in the office, I actually always have their records. I have notes from the consultants. I have all their labs, and I never, ever, ever, ever have to talk to, somebody at Walgreens again. Like the EMR has made my life 1,000 times better.
Oh,
Okay.
that's great. That's awesome.
But for some reason, right, we have shot ourselves in the foot as well. And some of it came from the outside with the billing, but some of it is our responsibility where I think because, I don't know, we're lazy, we don't understand what our real worth is. Um, we don't spend the time on what's important, and we spend a lot of time on the stuff that's not important. And for listening to you, I think your notes and my notes are pretty similar because
Yeah,
we've sort of moved beyond that. And it's like I have a very small amount of time I can take to do this documentation, and I'm going to make it valuable for the people who are actually going to use this note. And that's it.
yeah.
Um,
Do you think AI is going to help you? Did they bring it yet?
Also, I am not using it, but my colleagues are using, the ambient documentation software
Yeah.
that listens to the visits and documents for them.
Why aren't you using it? It's very, very interesting.
Yeah, so I'll tell you. Let me say first, most of them are actually very happy with it, and you know, some of it's amusing because some of it goes on for much too long when they take off a skin tag and it documents an entire paragraph rather than just like I clipped off a skin tag. What the hell? Um, so I do think that that'll help some people, though I don't think it's a great breakthrough. I have not adopted it, one, because, I'm at the point my documentation really takes me almost no time. Um, I push a button, my notes created, I copy and paste in my previous assessment and plan. I don't even do an HPI, it's all in one place. And I edit that, to update the visit. So, I mean, 2, 3, 4 minutes per for a visit. And the time that I do my thinking, I tend to sort of think when I write and think with my fingers. And every single day, I come up with a diagnosis while I'm documenting because that's when it all kind of comes together with me.
Yeah.
And I actually think it would sort of be dangerous to remove that from my practice um, because just the habit of my workflow is that, yeah, a lot of times I'm smart and I come up with what's going on when I'm seeing the patient, but there are a lot of times that I got to run out to the coordinator and say, wait, I had an idea as I was putting this all together. And I think that if AI was doing that for me, I probably wouldn't make those connections.
Oh, very interesting. Yeah, I write appeal letters on the kind of for our group on the side, and there's an ambient document transcription. It's amazing. Like you
Yeah,
just talk to it,
yeah,
and I don't have to say period, comma, semicolon,
yeah,
capital,
yeah,
and it just writes. I can just say the patient did this, and it writes the letter.
yeah,
That's I mean, that's what I think would be nice to say. It just listens to what I'm doing. I just talk to it and then it just generates the documentation. I still have to look at it and edit it because once you sign your name, you're
right. It's
attesting
yours.
that that is what you say it is. And
Yes.
I just started using Microsoft Copilot, and it's not all that it's cracked up to be, right? And so I think that's where I would want it just to help with the writing of the note. And as a writer, I refuse to let AI write anything for me. I
Mhm.
still write the letters. I tell it what I'm looking at, and it tells it, and it writes it. But I'm not any of my newsletters. I don't want AI to write for
Yeah.
me. Any of my sensible medicine thing that I'm going to submit to you, I'm going to write it. I'm not going to ever have AI do it. I can't. I'm a writer.
Yeah.
That's what's very important to me. So
Yeah.
what would be nice is like if AI could pull in all the problems from the labs or tell you, oh, or put it, that's where it can help so that you don't have to, or summarize previous stuff
Yeah.
accurately? Is that where you think maybe that the value would be?
I do. I still feel that maybe we don't know enough and we're not creative enough to understand where this is going to help us the most. I go back and forth between thinking it's going to be wonderful because it'll decrease workload, or it'll be, a wonderful assistant and help us with, sort of management plans and diagnosis, to being utterly freaked out about it, that what it's going to do is basically do all of medicine. And the only thing that I'm going to be asked to do is kind of interact with the patient because it's not good at collecting that kind of data. And so AI will be using me as like a data collecting tool, and that'll be
Oh,
it. Um, I'm sort of confused. And like you, I'm amazed the when I use it for things like, hey, can you check this for grammar mistakes, or I need a quick summary of things. It's incredible.
yeah.
But as you say, for my writing, I'm writing because it's me. I'm writing to figure things out for myself. Um, I could never use it for that, but we're very different from a lot of the way the rest of the world looks at writing, right? Where it's
No,
a
I mean
task to be accomplished.
that's true, and I'm sorry. It's like it's something that I'll never give up. Writing is
Yeah.
it's very personal to me. Again, I recommend everybody to sign up and subscribe to the Substack and become a supporter of the work. It's fantastic.
Thank you.
Um, what to close, the kind of what pieces of advice you have for my daughter first year medical school,
Yeah.
or residents and
Yeah.
medical students, residents, kind of how can you be better? And I'll take that and I'll take what you say to teach them when I
Yeah.
get a chance.
Yeah.
What kind of pieces of advice do you have?
Yeah. It's such a hard question because it's like, you don't want to be too pithy, and say obvious things. But I mean, I think what's important, and I think we both feel this way, right, is that it's an amazing field, right?
Right.
Um, it's this incredible kind of coming together of really interesting science, biomedicine, critical appraisal, all of that stuff, which even on its own would be great, right? But then it's applied to, bettering, human existence, right? To relieving
Yeah.
suffering, to prolonging life. Like, what the hell more could you ask for? Um, and so I try to kind of get people fixated on like, this is an amazing thing to do. It's an unbelievable privilege to actually do it, like to come to work doing this, and whatever, for 30 odd years, I still just love doing it. Um, but like every privilege, there's a cost to it, and you got to earn it. And the earning is, it's stressful. You got to take responsibility for things. You get blamed for things that weren't your fault. You have to work really hard. And you have to sort of recognize early on that the good comes with the bad, and just be honest with yourself, and be honest with yourself about, like, when you choose a field, that it's going to be something that not just that you imagine yourself being good at, but that you could actually be good at, right? Um,
Yeah.
and I think we've both done it in very different fields. And had I choose to do what you do, I'd probably be unhappy. If you chose to do what I do, you'd probably be unhappy.
Oh, I'd totally be unhappy. I mean, what solidified decision to become a specialist was by the way, I'm like 1 foot outside the door.
Yeah,
Doctor, by the
yeah,
way, I can't see. And
right.
this is a true story. I
Right.
can't see, and I
Yeah,
haven't been able to see for the last week.
yeah,
I'm like, what?
yeah, yeah.
And I'm like, that's it. I'm gonna go to the I'm
Right.
going to the specialist office.
How could blindness not be in the most important things during this 20-minute
Uh,
appointment that we just finished?
exactly. Like, why have you mentioned to me now?
See, and I love that.
That's perfect. That's perfect. That's fantastic advice. thank you for what you do. Thank you for the Sensible Medicine Substack. It's amazing.
Thank you.
I like my primary a lot, and he's been very nice. That's why I'm not switching to you. But it's been an honor and a privilege to have you on the show, and I look forward to contributing to Sensible Medicine and getting all of your work. And Dr. Cifu, thank you so much for being on Healthcare Musings.
Absolutely. Really appreciate it. Take care.
Thank you for watching. Sign up at healthcaremusings.com to get every episode delivered directly to your email. And please don't forget to leave a 5-star review. Thank you so much.